Welcome to Board Pearls. This is episode 1 of 3 of the Pelvic Floor and Anorectal Disorders chapter in the Colorectal and Pelvic Floor Disorders module. This episode is Chronic Constipation Pharmacology and Opioid-Induced Constipation, the Empiric laxative sequence, the prescription drugs for refractory chronic idiopathic constipation, and the peripherally acting opioid antagonists that target opioid-induced constipation without crossing into the brain. The first thing to get right is that chronic constipation is defined by symptoms, not stool frequency alone. Most patients who say they're constipated pass stool more than 3 times a week. What they're reporting is straining, hard stools, incomplete evacuation, and dependence on manual maneuvers, because constipation in adults is a syndrome of impaired colonic propulsion, impaired defecation mechanics, or both, so the lived experience maps imperfectly onto a single number. The criteria capture this by anchoring the diagnosis to a constellation of features over at least 3 months: straining, lumpy or hard stools, a sense of incomplete evacuation or of anorectal obstruction, manual maneuvers, and fewer than 3 spontaneous bowel movements a week, with more than a quarter of defecations affected, loose stools rare without laxatives, and IBS criteria not met, because the patient with pain-driven constipation belongs in the IBS-C category from the prior chapter. The teaching point the boards plant most often is that infrequent bowel movements alone don't satisfy the criteria, so the young woman with 2 easy Bristol 4 movements a week and no sense of incomplete evacuation has bowel frequency variation, not chronic constipation, and the right move is reassurance, not a Secretagogue or a transit study. Beneath that label, chronic constipation splits into 3 mechanistic patterns that drive workup differently. Normal transit constipation is the most common, where the patient has the symptoms, but measured colonic transit is normal. Slow transit constipation is less common, where the colon moves stool too slowly with reduced propagated contractions and a blunted response to fiber and stimulants. And defecatory disorders, about a quarter, are failure of the coordinated pelvic floor relaxation that should accompany the abdominal push. The 3 overlap frequently because outlet dysfunction chronically retains stool and produces secondary slow transit, and slow transit produces secondary straining. You have to hold them separate, because escalating laxatives and unrecognized outlet dysfunction produces overflow and urgency without solving anything. And operating on unrecognized outlet dysfunction produces incontinence without relief, which is episode 2. This episode stays on the pharmacology that works when the dominant problem is colonic, not outlet. Empiric therapy without testing is right in any patient without alarm features, because most respond and the yield of testing is low when red flags are absent. The alarm features collapse the empiric path to early colonoscopy, new symptoms over age 50, unintentional weight loss, bleeding or iron deficiency anemia, a family history of colorectal cancer or IBD, fever, severe progressive symptoms, or a colonoscopy overdue for the age. So the older man with a few months of new constipation, weight loss, and a dropping iron deficiency hemoglobin isn't the patient for empiric polyethylene glycol. He's the patient for colonoscopy now, and probably both ends give an iron deficiency in an adult man. When alarm features are absent, the next step before empiric therapy is to canvass for secondary causes, pulling the medication list first because polypharmacy is the most common reversible contributor. Opioids are the most potent constipating drug, and tolerance to the constipating effect never develops even as tolerance to the analgesia does. Anticholinergics reduce cholinergic propulsion, calcium channel blockers slow smooth muscle, and iron, ondansetron, aluminum antacids, calcium, clozapine, and tricyclics round out the list. So the older woman on amlodipine, oxybutynin, iron, ondansetron, and tramadol with new severe constipation has 5 contributors at once. With the tramadol, an opioid started when the constipation began, usually dominant, and the move is to minimize each and treat the opioid effect specifically when stopping it isn't feasible. The other secondary causes to screen are endocrine, electrolyte, and neurologic. Hypothyroidism slows transit, so the patient with constipation plus weight gain, fatigue, and cold intolerance gets thyroid testing before a laxative trial. High calcium and low potassium or magnesium slow the gut, and diabetes with autonomic neuropathy, Parkinson's, multiple sclerosis, and scleroderma all cause secondary constipation, so the initial labs are thyroid, calcium, glucose, electrolytes. Once secondary causes are excluded, the empiric sequence begins with education and diet, coaching on normal bowel frequency variation, avoiding laxative dependence, and timing defecation after meals to exploit the after-meal colonic response. Soluble fiber is introduced gradually toward 25 to 30 grams a day, with psyllium preferred because it forms a viscous gel that softens stool with less fermentation, while wheat bran and other insoluble fibers produce more bloating without proportional benefit. So the patient started on wheat bran cereal who now has worse bloating and gas has been given the wrong fiber, and the move is to stop it and start psyllium slowly with adequate hydration. Polyethylene glycol at 17 grams daily titrated to effect is the first-line osmotic laxative, holding water in the lumen with minimal absorption and minimal electrolyte disturbance, while lactulose works similarly but ferments to more gas, and magnesium salts are limited in renal impairment. Stimulant laxatives, bisacodyl and senna, are added when osmotics alone are insufficient, acting on the colonic mucosa to stimulate propagated contractions. And the old teaching that chronic stimulant use damages the myenteric plexus isn't supported by current evidence, so chronic use is acceptable when symptoms require it. The Empiric trial runs 4 to 8 weeks, so the patient with months of straining and hard stools, low fiber intake, and no alarm features gets polyethylene glycol plus titrated psyllium with reassessment in a few weeks, and a secretagogue, a colectomy, and sacral nerve stimulation are all not the first move. Pregnancy shifts the sequence. Psyllium and polyethylene glycol are first line and considered safe. Lactulose has the most reassuring data. Stimulants are acceptable short-term. The prescription secretagogues have insufficient human data, and mineral oil is avoided for fat-soluble vitamin malabsorption, so the pregnant patient who's progressed despite polyethylene glycol and psyllium gets lactulose, not a secretagogue. Now the second layer. The patient who fails 8 weeks of optimized osmotic, fiber, and stimulant therapy needs a prescription drug, and the choice is mechanism-driven, with 4 molecular targets approved for chronic constipation. 3 on the enterocyte surface, the chloride channel, the guanylate cyclase receptor, and the sodium exchanger, all ending with water in the lumen by different routes, and the 4th, the serotonin 4 receptor on enteric neurons, driving motor activity rather than secretion. The boards plant the mechanism in the stem and ask you to match drug to mechanism. Lubiprostone activates the chloride channel, pulling water in to soften stool, dosed at 24 micrograms twice daily for chronic constipation versus 8 micrograms twice daily for IBS-C, approved only in women, and that threefold dose split is a favored test point, with nausea the dominant side effect, mitigated by taking it with food. Linaclotide is the first guanylate cyclase agonist, raising cyclic GMP to drive secretion, and the same signal reduces visceral pain through submucosal nerves, which gives it an analgesic benefit in IBS-C beyond laxation, dosed at 145 micrograms daily for chronic constipation, with a lower strength for those who can't tolerate it, versus 290 for IBS-C, taken on an empty stomach 30 minutes before the first meal because food increases the diarrhea, and contraindicated in plecanatide is the second guanylate cyclase agonist, identical in mechanism but pH-dependent in its activation, giving a marginally lower diarrhea rate, dosed at 3 mg daily for both indications, essentially interchangeable with linaclotide, with coverage often driving the choice. Tenapanor inhibits the sodium exchanger in the small intestine and proximal colon, leaving sodium trapped to draw water in, with minimal systemic absorption, dosed at 50 mg twice daily before meals, approved for IBS-C, and used off-label in chronic constipation, with diarrhea the main side effect. Prucalopride sits apart because it's a prokinetic rather than a secretagogue, a selective serotonin 4 agonist that boosts acetylcholine release and stimulates the high-amplitude propagated contractions that move stool, dosed at 2 mg daily, one in severe renal impairment, approved for chronic constipation, with headache the most common side effect. Its cardiovascular safety is the tested part. The earlier serotonin 4 agents had off-target activity at another receptor in a cardiac channel and were withdrawn for arrhythmia and ischemic events, while prucalopride was designed for selectivity and spares those targets, giving it a much better cardiovascular record, though prescribers still review baseline risk, and the mechanism makes it the right next step in refractory constipation when secretagogues have failed, because the deficit there is slow propulsion, which serotonin 4 agonism addresses. Selection across the prescription class is mechanism-aware but driven by tolerability and cost. A patient who fails one secretagogue can try another from a different class, since the 3 reach the lumen by distinct routes, and prucalopride is the natural next step when secretagogues fail, because the problem is likely slow propulsion rather than insufficient luminal water, with combinations sometimes used in refractory disease. So the favored stem is a patient already on polyethylene glycol and a stimulant who needs a prescription drug, with the mechanism named in the stem. That covers chronic idiopathic constipation. Opioid-induced constipation is mechanistically distinct, with a different drug class. Opioids bind receptors on enteric neurons throughout the gut wall, suppressing acetylcholine release, so propagated contractions fall, non-propulsive segmenting contractions rise, and sphincter tone increases, and the prolonged colonic dwell time lets excess water get absorbed, so the stool is dehydrated and hard. The crucial point the boards plant is the asymmetry of tolerance. Tolerance to the analgesic effect develops over weeks, but tolerance to the constipating effect does not, because the enteric receptors don't downregulate the way the central ones do. So the patient on chronic oxycodone for years with stable analgesia but worsening constipation is showing exactly this, and the consequence is that opioid-induced constipation needs continuous management throughout opioid therapy and can't be waited out. A substantial fraction of patients on chronic opioids develop it, and the first-line response is still standard laxatives because many respond, with the guidance emphasizing that traditional laxatives should be tried before the targeted drugs, pairing a stimulant at bedtime with an osmotic, titrated to soft stools a few times a week, while fiber alone is inadequate because the problem is slowed transit and increased fluid absorption, neither addressed by bulk. So the patient new to opioid constipation gets Senna plus polyethylene glycol, not a targeted antagonist first line. When standard laxatives fail after a few weeks of optimized therapy, the next move is a peripherally acting opioid antagonist, designed to block the enteric opioid receptors that drive constipation while sparing the central ones that mediate analgesia, accomplished by being structurally modified to cross the blood-brain barrier poorly, so they work in the gut without central antagonism, withdrawal, or loss of pain control. That selectivity is the entire teaching. A drug that crosses into the brain and antagonizes opioid receptors centrally is naltrexone, used for opioid use disorder because it reverses analgesia, along with the peripheral effect, whereas these agents preserve analgesia while reversing constipation. The three approved for opioid-induced constipation in chronic non-cancer pain each use a different structural trick to stay out of the brain. Naloxegol is a pegylated naloxone derivative dosed at 25 mg daily on an empty stomach, dropping to 12.5 in renal impairment or with moderate interacting drugs, and contraindicated with strong inhibitors or inducers of its metabolizing enzyme because those can raise levels enough to compromise the selectivity. Methylnaltrexone carries a permanent charge that blocks brain penetration, available subcutaneously with All three share one critical contraindication the boards test directly, known or suspected mechanical GI obstruction, because the mechanism of harm is the mechanism of benefit, since unmasking proximal propulsion that was held in check pushes against the obstruction and perforates, and conditions like advanced peritoneal carcinomatosis, recent GI surgery, and Ogilvie syndrome also require careful evaluation. So the chronic pain patient with refractory constipation, despite osmotic and stimulant laxatives, gets one of these drugs, while the same patient with pain, distension, and a question of obstruction does not. Alvemapan is the one not to confuse with these, because its indication is different. It accelerates recovery of gut function after bowel resection with primary anastomosis, meaning postoperative ileus, restricted to short-term inpatient use under a risk management program with a small maximum number of doses, because long-term outpatient use in chronic pain showed excess cardiac events. So the teaching point is that alvemapan is for postoperative ileus, not chronic opioid constipation. And lubiprostone is approved for opioid-induced constipation as a non-antagonist option because its chloride channel mechanism is opioid-independent and works regardless of enteric opioid signaling. So the algorithm for opioid-induced constipation is layered. Consider opioid taper or rotation when the pain allows, add prophylactic and reactive stimulant plus osmotic laxatives, escalate to a peripherally acting antagonist when standard laxatives fail after a few weeks, choose among the three by route, drug interactions, and renal function while recognizing the shared obstruction contraindication, use lubiprostone when an antagonist isn't tolerated, and reserve alvemapan for the postoperative ileus patient only. So carry three things. Chronic idiopathic constipation is a symptom-defined diagnosis with three mechanistic subtypes, and the empiric sequence of education, soluble fiber, osmotic, and stimulant laxatives resolves most patients before any prescription drug, with the refractory drugs mapping onto four molecular targets chosen by mechanism, secretagogue to secretagogue switching when one fails, and prucalopride as the prokinetic next step. Opioid-induced constipation is mechanistically distinct because the enteric opioid receptor doesn't develop tolerance the way the central one does, and the peripherally acting antagonists exploit the blood-brain barrier to block the peripheral effect while preserving analgesia. Episode 2 picks up the constipation phenotypes that need more than pharmacology. The defecation disorders, where the lesion is mechanical at the outlet and doesn't respond to escalating laxatives but to biofeedback, and slow transit constipation that survives medical optimization and opens onto the colectomy question, with the favored pitfall being operating on unrecognized outlet dysfunction. So the move before the surgeon is anorectal manometry and balloon expulsion to confirm the outlet isn't the problem. For the full chapter, the practice vignettes, and the topic-tagged question bank, head to boardpearls.com. You'll find the rest of the series on Apple Podcasts, Spotify, or wherever you listen to podcasts. That brings us to the end of episode 1 of 3 of chapter 16, and I'll see you in the next one.